Hello, my name is Mona Bahouth. I'm a stroke neurologist and the medical director of the Brain Rescue Unit at the Johns Hopkins Hospital. In this series, we have been focusing on concepts in early stroke recovery care. In the first module, we discussed several physiologic concepts and early complications that are relevant to early post-stroke recovery. In this session, we will now apply that information as we conceptualize the incorporation of that information into early activity after stroke. Our session will include 3 parts. First, we'll discuss early stroke recovery challenges and opportunities. Second, we'll review some literature that guide our principles in the early recovery period. And finally, we will summarize some strategies for safe activity in the early stroke recovery period. In the prior sessions, we focused on optimizing physiology and preventing complications. We will now apply that to the concept of promoting post-stroke activity. And while we know that activity is important for stroke patients to recover, it is easier said than done. First, there is a limited window of opportunity for brain repair after stroke. Therefore, what we do in the first weeks and months are particularly important, especially for motor recovery. Secondly, activity and movement are essential to recover from stroke, but stroke itself leads to paralysis and cognitive disturbances that make it difficult for the patient to engage in complex therapies. And finally, bed rest leads to additional complications that can interfere with recovery activities. Both in the published literature and recent scans of comprehensive stroke centers still demonstrate that hospitalized stroke patients spend a majority of time in bed, and those with intracerebral hemorrhage may be particularly at risk. And we know that bed rest is bad. I don't have to tell this group that there are many complications of immobility, and as we look at this diagram, we're reminded that those complications really affect the human body from head to toe. Specific to stroke patients, medical complications such as deep vein thrombosis, pneumonia, skin breakdown, constipation, a propensity for delirium, and muscle deconditioning are all particularly concerning. And as you may remember from the first module, complications that occur in the early stroke recovery period have long-term impact on functional outcome after stroke. And while avoiding these complications are critically important in the early period after stroke, we also have to set our sights on getting the right activity delivered to the patient in the early period after stroke. Brain repair is a limited window of opportunity. This is the period when the brain has its best chance of recovering to its most optimal functional status. And we can see from this graphic that that critical period for rehabilitation occurs on the order of days and weeks after stroke, ending perhaps up to 3 to 4 weeks after stroke itself. This is the period of time when there is upregulation of growth-promoting factors that may propel a person's brain recovery forward, offering them the best functional recovery after the stroke themselves. Therefore, merging these concepts together, guidelines recommend that early rehabilitation for hospitalized stroke patients is a priority, and it is recommended that stroke survivors receive rehabilitation at intensity that's commensurate with their anticipated benefit and tolerance. That way, we avoid the consequences of bed rest while optimizing movements that will enhance recovery during a peak period of critical gains. But implementing these guidelines may not be as easy as it sounded. In this slide, I summarized several early studies that focused on very early mobilization after stroke. You can see that an early trial by Bernhardt and colleagues in 2008 suggested that early mobilization, if delivered at 18 hours after stroke versus 31 hours, suggested a possible improvement in functional outcome using the modified Rankin score. However, several other studies, observational studies, and small cohorts after that suggested no significant difference in those intervention groups. In 2015, however, a large multi-center prospective study was released and this time suggested that very early mobilization after stroke resulted in worse functional outcome. Now let's dig into that a bit more. The AVERT trial, a very early rehabilitation trial, incorporated strategies to initiate active mobilization within 24 hours from stroke onset in the intervention group. The intervention group had guided task-specific activities for each session. If the patient was in a low arousal group or fairly dependent, their section goals may focus on active sitting with assistance for a short duration, between 10 and 30 minutes. If a patient were higher functioning at a level 4, their session may target standing and walking, and the duration goal was basically dictated by the patient themselves, with a minimum duration of session of 10 minutes. In this study, we note that passive sitting or resting in the chair was not considered a very early mobilization activity. Now, the results of these 2,100 patients enrolled in this multi-site study suggested that patients had a reduced odds of good functional outcome at 3 months, defined as a modified Rankin score of 0 to 2. And you can see that the adjusted odds ratio, adjusted for stroke severity and age, suggested a worsened outcome in the intervention group. One critique of this well-executed multi-center study was that the time to first mobilization was clinically similar between the intervention and control group. In the intervention group, time to first mobilization from stroke symptom onset was 18 hours compared to 22 hours in the usual care group. And while this is a statistically significant difference, some question whether the difference has clinical relevance. Therefore, the authors went on to conduct a dose-response analysis. And looking at the entire cohort, they summarized that the time to first mobilization was 20 hours. In terms of the dose of the intervention, patients received, on average, 5 out-of-bed sessions per day. This included 18 minutes of out-of-bed sessions per day when combined. And the total duration of out-of-bed sessions over the entire intervention period was 120 minutes. They then went on to perform a CART analysis to see if there were any inflection points that could give us any insightful information. The complex figure on the left is not intended to be read, but can be found in their publication in 2016. And you can see here that the basic points are summarized in the table next to that flow diagram. In essence, they divided by 3 cohorts of age. Age less than 76 years, age between 76 and 86 years, or greater than 86 years old. We are cautioned that patients above age 86 did not achieve favorable outcome in the intervention group, and therefore we should use caution when considering very early mobilization of that group within 24 hours of stroke onset. However, there were groups who benefited from very early mobilization within 24 hours of stroke onset. If you were under age 76, 70% achieved a favorable outcome, defined as modified Rankin score of 0 to 2, and this was under the condition of a relatively small to medium-sized stroke with NIH stroke scale score of less than or equal to 7.5. In the 76 to 86-year-old group, 58% of patients received a favorable outcome if they were enrolled with a low NIH score of less than 4.5 and when they were exposed to frequent short sessions. Now those short sessions were on the order of 13 minutes or less. Therefore, there is some information from this large multi-center trial that could guide our practice moving forward when considered safe, very early mobilization. These results inform our guidelines in the early stroke period, and they currently state that high-dose, very early mobilization within 24 hours of stroke onset may reduce the odds of favorable outcome at 3 months and is therefore not recommended. However, there are no data that guide what to do after the 24-hour period or for those patients in which the CART analysis suggested that even earlier mobilization may benefit the patient. Therefore, to plan our way forward, we revert back to the physiological principles discussed in the first module. As you may recall, disrupted autoregulation, as well as disruption of the blood-brain barrier, are 2 main concepts that regulate our decisions in the early stroke recovery period. But this slide reminds us that there are several other complexities to consider as we promote activity for the stroke patient in the early recovery period. In this table, we list several common issues the potential risks to the patient related to those issues, and several considerations as you design an activity program that may benefit your patients. For example, hemiplegia is common after stroke, which may place the patient and the staff caring for that patient at risk for injury. Therefore, in our care delivery models, we must consider the correct number of staff needed for safe movement of patients, as well as which supportive and targeted equipment our stroke centers might need to accomplish early activity and safely for these patients with hemiplegia. The next line item reminds us about blood pressure lability. As we know, blood pressures may be quite variable in the early stroke recovery period, which could lead to stroke extension since autoregulation is impaired. Therefore, our stroke center care must focus on monitoring patient for signs of alteration in cerebral perfusion and planning activities that help promote cerebral perfusion at a time that the brain may be vulnerable. Another example is post-stroke fatigue, which is common in up to 80% of patients post-stroke. This may affect a patient's ability to engage with therapy, and therefore they may not be able to gain the optimum output of the therapy sessions if they're too fatigued to participate. So in planning a program for early activity after stroke, you need to consider periods of brain restoration that are short but balanced with rest periods within the context of the day. And the other areas are listed here for your consideration. So we've considered that the solutions to promote early activity after a stroke are several-fold. First, any activity algorithms must be titrated to the patient's needs, and these should be regulated by protocols. Second, we need to bring the right tools to support the patient in a progressive early activity plan. We need to find ways to motivate the patient toward their therapies and to engage in them for the duration that may benefit them to the highest extent. We need to monitor the therapies closely and the patient's response to those therapies, and we need to be agile to modify those therapies based on that patient's physiologic response. Here I provide for you our activity and mobility algorithm implemented in the intensive care unit at the Johns Hopkins Hospital. It summarizes the concept that all patients should be included in an activity progression plan, and this progressive plan should really take into account the patient's tolerance of each level of activity. This activity algorithm is implemented by both therapists and nursing staff to assure that 24 hours a day the patient is advancing in terms of their activity that they are able to tolerate and progress to the next step forward. We demonstrated the impact of the implementation of such an algorithm in a cohort of patients with intracerebral hemorrhage who are admitted to the intensive care unit. Prior to the study, we identified that patients with intracerebral hemorrhage were maintained on bed rest for prolonged periods of time. After the implementation of the algorithm, we could see that patients' odds of mobilization increased over time, but most importantly, the number of time that patients were mobilized while hospitalized in the intensive care unit went up significantly. All the while, this did not change the amount of resource required in terms of the number of therapists, since this algorithm was accomplished by both therapists and bedside nursing staff. Implementing a progressive activity algorithm also requires the use of supportive equipment. The pieces of equipment that are most useful to patients with stroke in the early recovery period focus on concepts such as progressive verticalization, increased activity, and endurance training. All of these devices can be used on a broad range of patients, from patients who are comatose or have decreased level of responsiveness, all the way up to patients who are engaged and highly active during their session. We have demonstrated in several observational studies that use of these devices are both safe and meaningful towards a stroke patient's recovery. And this progressive activity algorithm was even safe in our sickest patients hospitalized in the neurocritical care unit at the Johns Hopkins Hospital. In this group of patients placed on progressive cycle ergometry, you can see here that both hemodynamic and intracranial pressures did not change during the pre-post cycling measurement periods, suggesting that cycle ergometry is safe even for patients who are prone to elevated intracranial pressure. In the bottom graph, you can see that in the subgroup of patients with external ventricular devices also demonstrated no significant change while exercising in the intensive care unit using cycle ergometer as a support tool. This is important to recognize as many times activity progression is halted when the patient is sick with issues of intracranial pressure or hemodynamic status issues. Another critical element in our progressive activity algorithm is incorporation of upper extremity activities. Very commonly in the hospital setting, the upper extremity is avoided in terms of exercise as the focus is more on safe ambulation and walking for the progression of the patient towards home. We have found, however, that patients both tolerate and enjoy use of the upper extremity cycle ergometer to use during times when they're inactive and sitting in a chair as a part of their activity planning. Listed here is the algorithm that we use to adapt this device for critically ill patients with neurologic illness. And it is safe to perform upper extremity cycling in even the sickest cohort of patients. In this study, we looked for safety issues when incorporating the upper extremity cycle ergometer algorithm for our patient population. On this graph, we demonstrate that there was no change in intracranial pressure in the cohort of patients that had external ventricular device when using the upper extremity cycling patterns. This suggests that we do not have any issues with line dislodgement or patient intolerance even when they are sick in the hospital or intensive care unit. As we discussed previously, many of our population have had limited experience with exercise prior to their stroke or may be undermotivated to participate in their therapies once the stroke has occurred. Therefore, we have taken to the approach of gamification of our early stroke care in order to motivate patients and encourage them towards progressive activity. In this study, we enrolled several patients into an algorithm that was generated by a multidisciplinary team to choose the right game to encourage activity to patients with several domains of post-stroke injury. As you can see in the picture here, this patient is enjoying gaming while on a ventilator to increase her activity while standing with the therapist to promote sort of movement out of bed. This algorithm is not intended to really focus on the domains of injury, however, to increase activity levels for patients with certain deficits. In future modules, we will discuss our highly immersive gaming experience for patients with stroke that incorporates high-intensity, high-quality movements for recovery of multiple domains of post-stroke deficit. This is essentially changing our paradigm of post-stroke care and will be discussed at length in a future discussion. Taken together, a system of care that encourages activity after stroke must rely on a cohesive plan, protocolized activity, highly specialized individuals working together to accomplish those goals, and a monitoring system that identifies any contraindications or adverse events secondary to those interventions. The system of care in the early recovery period relies on an interdisciplinary team, each bringing their unique expertise, observational skills, and innovative planning for each individual patient to achieve the highest level of function after their stroke. I hope you have found those extraordinary people at your facility. As you can see, it requires an army of specialists, all vigilantly focused on one goal, to improve the life of every stroke patient. Together, we can really make a difference for each patient to deliver the right therapies at the right time to each individual. So to summarize, time is critical in the early management of stroke patients. What happens in the first few days and weeks are important to the patient's long-term recovery. Specialized stroke care with attention to activity as an important part of the care plan is important in the first few days after stroke and will reduce complications if executed properly. But early activity must be guided by physiologic monitoring to assure the safety and benefit to each patient. And finally, teamwork is essential to bring the right treatment to the right patient at the right time. And I want to thank you for your attention. I hope this has been a helpful session for you, and I will look forward to conversation through both email and in the interactive session coming forward in the future. Thank you for your attention.